Okay, we're gonna move on to hernias for Unit 4. So what a hernia is a protrusion of an organ or structure through the defect in the muscular wall of the abdomen. This is classified by location. You can see some different locations on the next slide. They can be congenital or acquired. It is usually due to the weakening of the muscles of the abdomen, which can be due to surgery, trauma, like due to heavy lifting. Gradual increases in intra-abdominal pressure caused by pregnancy, obesity, and ascites. This is usually the bowel that protrudes through the abdominal wall, but it can also be other tissues like fat. Assessment depends on where it's going to be, but usually you can put your hand on that bulge and have the person cough, and if it really bulges out with the cough, then you pretty well know that it's a hernia. There are several different types, so there's assessment findings for inguinal, umbilical, and a ventral incisional, which is due to an incision. Reducible means that you can push that sac back into the abdominal cavity. Irreducible or incarcerated are more severe and they can't be pushed back in. Consequences, we worry about a bowel obstruction. If the bowel of the lumen is, or lumen of the bowel is through the abdomen wall, then it can become occluded like the crimping of a hose. Strangulation, which is the actual hernia itself, is not going to get perfusion. So then we worry about ischemia, necrosis. That would be manifested by severe pain, distension, nausea, vomiting, tachycardia, and fever. Treatments, it's almost always going to be surgical with 3 weeks of healing time. Patients are going to need to be placed in an abdominal binder to help with healing and comfort. If there is no surgery, then the patient is taught how to reduce the hernia on their own. So here's a picture of all the different types of hernias. All right, hemorrhoids. Hemorrhoids are distended and weakened veins of the anus and anal canal due to pressure from venous return that is increased or impaired. They can be internal or external. So the most common cause is going to be straining with defecation, that putting pressure with that Valsalva maneuver. Other common causes would be pregnancy, prolonged sitting, obesity, low fiber diet, or chronic constipation. So anything that causes that extra straining, that extra pressure. So like I said, they can be internal or external. So internal are generally asymptomatic. There can be bright red blood, especially like on the toilet paper after wiping or in the toilet itself. They can become large and prolapse through the anus, and then patients usually complain of having an incomplete stool evacuation feeling. External hemorrhoids, the bleeding is rare. There is a feeling of pressure and then difficulty cleaning after defecation. They're protruding, they're irregular in shape, hard to clean around, plus they can be painful to where the person just doesn't want to get a good clean around them. So then we worry about, infection. They can be asymptomatic to mild irritation. I hate that because truthfully, patients can be extremely uncomfortable due to this. They can be in a lot of pain due to hemorrhoids. And consequences, prolapses may become strangulated, leading to thrombosis within the hemorrhoid. Those are extremely painful, can rupture and bleed profusely, especially if there's liver problems. Some treatments and nursing interventions. We're going to recommend a high fiber diet with increased water intake. They may need a docusate sodium, which is a stool softener, to keep the stool nice and soft, easier to pass, so there's no straining. We do recommend people to not use the Valsalva maneuver, to just let their bodies kind of evacuate stool on their own. It might take a while, but it's better to just let the body naturally do its thing instead of forcing it to do its thing. Topicals like Preparation H and Nupercaine are for comfort only. They're not going to actually get rid of the hemorrhoid. Warm sitz baths and bed rest can be useful. And then if you do have that thrombosed hemorrhoid, then they're going to need to be lanced and debrided. This is extremely painful. I've assisted in a few of these. Patients are in terrible pain when they come in. Like, they can't even sit. They're laying down on the table. They can't. They're out of their mind with the amount of pain that they're in. And then lidocaine is just not sufficient for pain management with these. So patients usually can feel, the scalpel and then the doctor digging the clots out. But then once those clots are removed, the patients will have like almost immediate relief of that pain. Sclerotherapy is injecting a chemical irritant into the tissue surrounding the hemorrhoid, causing it to scar off. Rubber band ligation, this is where rubber band is placed around the hemorrhoid, and then it's allowed to necrose and then slough off on its own. And then a hemorrhoidectomy is surgical removal of the hemorrhoid. They don't like to do those because, well, they can bleed quite a bit. So it's better to do like something like the rubber band ligation. So here's a picture of normal veins, and then here's an internal hemorrhoid and an external hemorrhoid. And here's a picture of what an external hemorrhoid looks like. All right, colorectal cancer. This is the abnormal growth of cells in the colorectal area. Risk factors. So if it's recommended that you get your first colonoscopy at 50 years old, well then, so obviously a risk factor is 50 years of age or older. Personal or family history of colon cancer, polyp formation, inflammatory bowel disease such as ulcerative colitis or Crohn's disease, smoking, alcohol, physical inactivity, obesity, having a diet high in saturated fat and low fiber, inadequate fruit and veggie intake. Causes almost always caused by a polyp, which is a benign precancerous lesion that grows in the large intestine. There you can kind of see a little picture of it. These typically grow very, very slowly. We're talking 5 to 15 years. That's why we do a colonoscopy screening every 10 years. They are asymptomatic until they spread to other tissues, depending on size and location, how much discomfort can be felt. There may be some bleeding with defecation. The biggest thing, changes in bowel habits. So people can become either more constipated or having an increase in frequency of bowels. And this is more than just like a day of diarrhea. This is like for, weeks having this change that's happened. Anorexia and weight loss, because, well, cancer just takes a ton of energy and it's stealing it from the body. And then a palpable mass can sometimes be felt. Consequences, besides metastasis and that kind of thing, we worry about bowel obstruction from that mass, to be able to physically cut off the bowel so that stool cannot move through. Diagnostics, colonoscopy or sigmoidoscopy for biopsy of the polyps or even visualization of the tumor itself, a CBC for anemia, an X-ray or CT may be needed to check for metastasis of other tissues. Treatments, almost always it's going to require a surgical treatment. They're going to have to physically go in and remove that tumor that has formed. A colostomy might have to be placed because, they're not going to just take the tumor. They're going to take the colon that's around the tumor, and depending on how much they have to take, there might not be enough to reattach to itself. So they may need to put in a colostomy bag. And it could be a permanent thing, or they may say, you know what, let's get done with chemo, radiation, let's get you all cancer free, and then we can go ahead and reattach these for, we want good perfusion and good healing there. Adjacent therapy would be like chemo and radiation. Nursing therapy is going to be specific to acute pain, grieving, and sexual dysfunction. That is the end of this lecture. Continue listening for impaired